Good morning. For those of you who are not familiar with the Bipartisan Policy Center, the organization was founded 10 years ago by 4 former Senate Majority Leaders: Howard Baker from Tennessee, Bob Dole from Kansas, George Mitchell from Maine, and Tom Daschle from South Dakota. The Health Project, which I direct, is headed up by Senator Tom Daschle and former Senate Majority Leader Dr. Bill Frist. This organization was put together to help find bipartisan policy solutions. And I think when the leaders put the project together 10 years ago, they had no idea what the situation was going to be today. And I think our organization is needed now more than ever, and the challenges are just unbelievable. So before I talk about our recommendations, I'd like to share with you a little bit about our process and how we reach our recommendations. First of all, we draw from existing research and identify gaps in research and fill that in, whether it's qualitative or quantitative research. We then engage stakeholders either through public meetings, through private roundtable discussions, or through individual meetings. We then sit down with our senior advisors, one of whom is here today, Tim Westmoreland. They're a cadre of former agency, yes, Tim back there, who is now quite embarrassed, I'm sure, cadre of former congressional staffers, agency staffers, White House staff, some having worked at the Office of Management and Budget, the Congressional Budget Office, former academicians that really help us navigate the process and come up with these policy recommendations. Ultimately, we are accountable to our leaders who make the final policy decisions. When we reach a difficult decision, we go to those leaders and ask them what they want us to do. And finally, our recommendations go through another filter, which is political viability and fiscal sustainability. Generally, our policy recommendations cannot add to the federal deficit. So I will point out to you that there is political viability. Sometimes we push the envelope there a little bit. And one of our recommendations, I think, pushes that envelope, and I will highlight that when I get to that. So as a former congressional staffer, what we try to do is go into a level of detail that we think would be useful to both agency staff and to congressional staff. We would like for them to be able, I think there was nothing more frustrating to me when I was up on the Hill than for folks to come to me with this great idea, and my question was, but how do I implement it? And that was the end of the story. No one knew how to implement it. So we go into, unfortunately, sometimes according to our leaders, a mind-numbing level of detail, which often we have to put in appendices. And for any of you who are interested, I also have some side-by-sides that don't even make it into the reports, and reach out to me if you're interested. But with that, I think I would like to start talking about our goals for this particular project and what our recommendations are in all seriousness. Our goal here was to look at existing reimbursement models, and I want to make sure and distinguish reimbursement models from healthcare delivery models, because we are talking about methods of payment here, not methods of healthcare delivery. And our goal here is to eliminate or mitigate barriers to the integration of Medicare and Medicaid services for individuals who are eligible for both Medicare and Medicaid. We will be working on another report that will be issued in April of next year on Medicare only. And our leaders have stressed in this report that this is a very vulnerable population and that we should move slowly as states learn more about providing services to this population, as plans learn, and as beneficiaries learn how to participate in these organized systems of care. It's very important. We don't know a lot about the quality of these programs in many respects. We are learning, particularly in quality measures for home and community-based care. So what are our recommendations? There are three basic areas. One is looking at existing reimbursement models, such as Medicare Special Needs Plans, SNPs. Two, the Program of All-Inclusive Care for the Elderly. And three, we make some recommendations on the Financial Alignment Initiative, a demonstration program that is currently underway through the Center for Medicare and Medicaid Innovation and the Duals Office, the Center for Medicare and Medicaid Coordination. Second, we propose a consolidation of regulatory structure within the agencies. This is unprecedented for BPC. We have never come out with recommendations before as to how the Secretary should organize an agency, but we felt this was really important. We believe that there should be a single agency within CMS, the Medicare-Medicaid Coordinating Agency, that has responsibility for regulating these programs, that looks at these programs from the perspective of the beneficiary and the perspective of the state, whose sole responsibility is to think of it from their perspective. Finally, could I get some water? Thank you. Got it out here and it's just not working. I'm starting to have a speech impediment. It was getting so bad. I'm starting to look like Donald Trump drinking water. And finally, we're suggesting a new regulatory structure that is based on what we've learned from existing programs and models over the last decade. Specifically, what we've learned from the PACE program, what we've learned from the dual special needs programs, and what we've learned from the Financial Alignment Initiative. And most particularly, we're adopting or suggesting adoption of the innovative three-way contract that was suggested in the Financial Alignment Initiative, which would allow the states, CMS, and health plans and providers to enter into a contract to provide services to individuals who are dually eligible for Medicare and Medicaid. And here's the part that we're sort of pushing the envelope of political viability here. So I want to flag this for you. What we're proposing for the first time outside the PACE program is allowing plans and providers to combine a capitated payment or a benchmark payment, such as an ACO benchmark or a patient-centered medical home benchmark similar to the Arkansas model. Combine those payments and cover anything that is reasonably related to improving or maintaining health and functional status. So they could address a lot of social issues so long as they stay within this benchmark. Now, this is something that has never been done before. As I mentioned, outside the PACE program, I got some ice now. I've got a little comedy routine going up here. So there are certain caveats here, having been a Hill staff. I used to work for John Chafee, and when we briefed him to go up to to go to the floor to make a statement, he always wanted to know what the chief arguments against his position would be, and we would tell him, and then we would watch him on the monitor, and he would lay out all the bad points in his proposal, and our chief of staff would look down and say, he's shooting himself in the foot here. Why is he telling? And then he would talk about, he would make those arguments, and then he would explain why it was really okay that we're doing this. So I will lay out the criticisms to doing this. Chiefly, there will be criticisms that individuals will be able to use, or plans will use this for marketing, will be able to use providing additional benefits for marketing to enroll healthier, younger, healthier Medicare Advantage beneficiaries into these plans. And we've addressed this concern by limiting this flexibility and benefits to high needs individuals and to benefits that are being provided as part of a care plan. So you would not be able to guarantee an individual going into a plan that they would have access to these benefits. We also would require that plans meet quality measures going into this, and also they stay within the benchmark. And we would also need to figure out a way to make sure that as we are spending or allowing spending of Medicare dollars on things that are typically today covered under community-based programs or covered under the Medicaid program, that we aren't supplanting existing dollars that are being spent by states on the Medicaid program. And that one is going to be tricky. And so I see Mark Miller back here. You didn't say anything, no. But you were thinking it. Yes, you were thinking it. So that is one of the challenges that we're going to have to work with. But our leaders really do believe that it is important to allow use of these funds to really address the whole patient and have the flexibility to develop a care plan that is really based on what a patient needs rather than what's covered under the Medicare or the Medicaid program. And by doing this, we can move forward and begin to provide services under these care models based on what we've heard today. So in closing, I'd like to thank the Peterson Center on Healthcare for bringing us together with the National Academy of Medicine and the Harvard School of Public Health. I'd like to thank the Commonwealth Fund and the SCAN Foundation for their assistance in this project as well. And thank you all and all of the partners here today.